everyone, then we can start.
Okay, sir.
Okay. So, good evening, everyone, and welcome to this online session of case presentation that we are conducting for last 3 years almost now. So, today we have a case presentation of chronic otitis media by a candidate from Civil Hospital, Panchkula, and we have expert examiners today. So, I'll just take a brief introduction of all the experts, and then we can proceed with the case. So first we have Dr. Sudeep Kaur. Ma'am is senior consultant and head at Civil Hospital, Panchkula. We have Dr. Ravi Meher, who is professor of ENT and head at Maulana Azad Medical College. He'll be joining us shortly. Then we have Dr. Uma Garg, ma'am. Ma'am is professor of ENT and head at BPS Kanpur. And last but not the least, we have a senior expert, Dr. J.C. Pasi. Sir is professor cum dean at World College of Medical Sciences, Jhajjar. So now, Dipanshi, you can start the case and take the permission of
सर का
examiners.
वीडियो नहीं है सर का वीडियो नहीं चल रहा
हाँ सर का वीडियो
I'll
ज्वाइन कर लिया है
coordinate
क्या?
with you. Yes. Dr. Pasi has joined.
I can see Dr. Sukhdeep and Dr. Uma only.
सर वी वुड
अच्छा।
लव टू सी यू
Okay.
Hopefully, yes.
Good evening, sir. Good evening.
Good evening.
सर
Very
मैच
good
देख
evening,
रहे
Dr.
हो
Bhushan.
वीडियो बंद करके
Switch on your video, sir.
Good evening. Hello, Dr. Bhushan.
Sir, good evening, sir.
A very good evening. How are you?
I am
All
good,
well?
sir. Thank you.
Let
आप
us-
ठीक हो, sir?
Let
जी.
us. हाँ, मैं अब ठीक हूँ. I have improved quite a bit. I have started moving around.
Oh, great, sir. Great. Sir, can we start, sir?
Yes, actually everybody is not visible. I can see only
Can you
Uma
see the
Garg and
screen?
Sukhdeep.
No, sir, can you see
And-
the screen long case presentation, the slides?
We can see the screen, sir.
No, I cannot see the screen and the presenter both.
Okay, so you just swipe your screen, either right or left. I think then you'll be able to see.
I swept it on the right side. This Dipanshi Rawal
Yes.
column
Yes.
is
Yes, sir.
not showing any picture.
No, this is the first slide only. Now she will start the case.
सर कैन आई स्टार्ट
Okay. You can see Dipanshi. Before we start, Dipanshi, I'd like to speak to my co-moderators. Have you earlier presented a case, Dipanshi?
Sir, not in this forum, but I have presented cases elsewhere.
Okay. I would like to speak to my other co-panelists as well as the organizer, Dr. Raman. Are we supposed to complete the whole chronic otitis media today, or we can divide it into parts and go into details?
Yes, sir. We have around 1 hour. So 15 minutes we can divide for each history examination. Then later half an hour for the discussion of the case or management of the case. Hello. So you have muted yourself. Please unmute yourself.
Yeah, Dr. Pasi's phone is muted.
Sir, you unmute yourself. Oh, Sunil.
I think, Raman, your idea of these 15 minutes is
Yes.
good.
Yes,
I think
sir.
we can start.
We can
because,
start, sir.
Yeah, because already 5 minutes
Yes,
are gone.
yes.
Yeah.
Okay, sir. With your due permission, I'm starting my presentation. Good evening, everyone. I am presenting a case of Mr. Gaurav Tripathi, 22 years old gentleman serving in railways and is a resident of Ramgarh, Haryana. My patient presented with the chief complaints of discharge left ear since 1 year duration and decreased hearing in both ears since 6 months duration. History of presenting illness. Patient was apparently well 1 year back when he developed left ear discharge, which was insidious in onset. continuous, yellow in color, thick and purulent, scanty in amount, foul smelling, and occasionally bloodstained. There was no aggravating factor. It was relieved by medication in the form of systemic antibiotics and topical eardrops, only to recur within a few weeks. And there was no history of ear discharge from the right ear. History of presenting illness continued. A patient also came with a complaint of decreased hearing both ears since last 6 months, left more than the right ear. Onset was insidious, gradually progressive. Hearing improved during discharge. Patient cannot hear whispers from the left ear and has occasional difficulty in hearing conversations, which is affecting his routine work. Patient has no difficulty in understanding speech and is able to hear loud conversations. And when the volume of television is increased, patient uses mobile phone with the right ear, and hearing is non-fluctuant in nature. Coming on to the negative history, there is no history of trauma, no history of fever and ear pain, no history of swelling behind the ear, no history of facial asymmetry, drooling of saliva, inability to close the eyes and blow air, no history of ringing sensation in the ear and dizziness, no history of pain behind the eye, double vision and abnormal movement of the eye, no history of headache, vomiting, blurring of vision, neck pain and weakness of limbs, no history of exposure to loud sound or exposure to ototoxic drugs, no history of imbalance and gait disturbances, and no other ENT complaints. Past history. There's no history suggestive of hypertension, diabetes, mellitus, and tuberculosis. Patient has a long-standing history of nasal obstruction and seasonal allergic rhinitis. No history of any drug allergy. There is no history of any ear surgery and any hospitalization in the past. Personal history. Patient consumes a mixed Indian diet. Patient has normal sleep and appetite. His bladder and bowel habits are normal. There is no history of tobacco chewing, smoking, or any alcohol intake. Family history, no history of similar complaints in the family, no history of any allergy in the family, no history of deafness in the family. Socioeconomic history, there are 4 members in the family and patient belongs to a low middle class according to modified Kuppuswamy scale 2018. Treatment history, patient has intermittently been using oral medication in the form of antibiotics, antihistaminics, decongestants, topical eardrops and nasal sprays, all from a local practitioner. There is no history of any surgery in the ear, nose and throat. My history part is complete. Shall I continue, sir?
So first 15 minutes for questions regarding history, sir.
Is discharge continuous or intermittent, you said?
Continuous. It never stopped. It was there only. It just
Even
Totally.
when he was taking medicines, it decreased in amount, you said.
patient
Then
was not regular in taking the medication also, and he took it from a local practitioner. And
But it was scanty.
yes, ma'am, it was scanty.
Okay.
Hello, Dipangshi.
Yes, sir.
Am I audible?
Yes, sir, you're audible.
You have stressed on the history of allergy in the family.
Yeah. Yes, sir.
How much relevant is this history in this case?
So,
Allergy in the patient is all right. Allergy in the family also you're trying to rule out. Any reason
No,
for
sir.
that?
No, sir. She's written no history of allergy in the family.
No
Only
history.
the patient is having.
Yes,
No
sir.
history.
Why do you need to know this? Why do you
So to rule out
need to
allergy.
this particular case?
So
In the
because
patient, no?
yes, sir, to rule out allergic rhinitis, so
Okay. If I take it like this, what is the importance of allergic rhinitis coexisting with the ear disease that you are presenting?
So allergic rhinitis is a predisposing etiological factor for chronic otitis media. So we're ruling out that. So I've taken this history.
How is that? How does this predisposes
So because
to hepatitis media?
so because it can cause eustachian tube blockage.
Okay. But
Can you
chronic
elaborate a bit?
hepatitis,
Because of the negative middle
chronic
negative.
hepatitis media it is an infective condition or an allergic condition?
So it is an inflammatory condition only. but it can be a predisposing factor because it can hamper the ventilation pathway and because of negative middle ear pressure. So it can cause eustachian tube dysfunction.
All right. Okay. Go ahead, please. Dr. Uma was saying something about the history.
No, I just asked her whether the discharge is continuous or intermittent. She said it was continuous. It just decreased in amount on taking medicines, but it was scanty and foul smelling. So that was what I
Okay.
asked.
Shall I
Okay, go ahead, please.
Go ahead.
General physical examination. Patient was calm, conscious, cooperative, and well oriented to time, place, and person. General condition of the patient was fair. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and pedal edema. Vitals were normal. Blood pressure was 120 by 76, and in the right arm sitting position. Pulse rate was 78 per minute, regular with good volume pulse. Respiratory rate was 16 per minute, regular, and renal examination was normal. Systemic examination was normal.
Dipanshi, for the lymphadenopathy, which
Yes, sir.
areas you examined?
So
Lymphadenopathy.
basically, in this case, I examined the neck of the patient for lymphadenopathy, sir.
So then you can say cervical lymphadenopathy.
Yes, sir, cervical lymphadenopathy.
There is no cervical lymphadenopathy.
Okay, sir.
Yes,
When you
correction
say
is needed in that.
lymphadenopathy, it is a very it's a very vague term. Lymphadenopathy, it can happen anywhere in the body.
Okay, so cervical lymphadenopathy.
Yeah, that will be better.
Okay, sir.
Okay, carry on.
So systemic examination was normal. Um, Coming to the local examination, examining the right ear first. The pinna was normal in size, shape, and position. The preauricular region, there was no scar, sinus, tag, swelling, or any fistula present. On the post-auricular region, there was no scar, fistula, and swelling. Tragal tenderness was absent. External auditory canal was normal. Coming on to the left ear, pinna was normal in size, shape, and position. There was no scar, sinus, tags, swelling present. Post-auricular region, there was no scar, sinus, fistula, and swelling. Tragal tenderness was absent. And on the left ear, in the external auditory canal, there was a foul-smelling yellow discharge present.
Do you want to comment on or you want to tell us about the retroauricular area or retroauricular groove?
Ma'am, I have written it in the next slide. It was not obliterated and mastoid tenderness was absent, ma'am.
Okay. Right.
Then coming on to the tympanic membrane picture. So this is a autoendoscopic picture of the left side. And coming on to the pars tensa, there was a grade 4 pars tensa retraction present. The ossicles were not seen, and there were retraction present in the posterior superior and posterior inferior quadrant. Sir, and there were cholesteatoma flakes present in the pars flaccida region, and there was a grade 4 retraction present. I tried to mop the discharge, but granulation tissue was present after that also. Coming on to the autoendoscopic picture of the right side, coming on to the pars tensa first, the cone of light is distorted, the handle of malleus can be seen, lateral process of malleus is visible, posterior malleolar fold is seen, anterior malleolar fold is not visible, and on the pars flaccida, there is a retraction present anteriorly, and there is a grade 3 retraction both of the pars tensa and pars flaccida.
Will you comment about annulus also, Bianchi?
Yes, sir, the annulus is prominent in.
Will you comment about annulus?
Yes, sir, the annulus is visible and
So very very prominently visible.
Yes, yes, sir.
And what about the stapes and the lenticular process and long process of incus?
Sir, I am able to appreciate the incudostapedial joint, so through the retraction.
Okay. All right. Can you go back to the left ear finding again?
Yes, yes, sir.
Right ear finding is more clear than the left one. You have already done an
Left ear
auto-endoscopic
is
examination.
not at all clear because as he mopped, it was all blood and granulation tissue. We could not take a better picture. It's actually not very clear.
On
Just
the
the
left side.
cholesteatoma flakes in the posterior superior region, that is the most prominent thing we could appreciate. Rest of the things.
Mhm.
Okay, Dipangshi.
Yes, sir.
Hello, Dipangshi. Should you
Yes, sir.
not describe the otoscopic finding first before
Uh,
going on to the auto-endoscope?
yes, otoscopic findings. Sir, I did that also, but I just put the pictures of.
Though of course,
Yes,
auto-endoscopic examination is a
yes.
part of the general examination now.
So I did the examination, but I put these pictures to display my findings better.
What could you appreciate on
We cannot
otoscopy?
forget otoscopic difference.
Yes, that's true. Otoscopic should be.
Note that because otoscopy is much more important before endoscopy, right?
I will take care of
Mhm.
it.
All right. So you can go ahead if there are no more questions.
Shall I continue, sir?
Yeah.
Yes.
Coming to the ear examination, I performed the tuning fork tests on the right side and the left side. Right side, Rene's was negative with 256 hertz and positive with 512 hertz and 1024 hertz. And on the left side, Rene's was negative with both 256 hertz and 512 hertz and positive with 1024 hertz. My Weber's test was lateralized to the left side, and absolute bone conduction test was not reduced on both the sides. Sir.
So
Hmm.
what is the inference?
So my inference is since on the right side it is negative with 256 hertz, so there is mild conductive hearing loss on the right side, and it is negative with 256 and 512 on the left side, and my Weber's is also lateralized to the left side, that is the more diseased ear. So I'm suspecting a moderate conductive hearing loss on the basis of tuning fork test. So.
Okay. Now the patient in the history did not complain of any hearing loss in the right ear, right?
No, sir, hearing
No.
loss was present in both the ears, but
Yeah.
discharge was not present in the right ears.
Okay. I stand corrected. Okay. Any questions, Dr. Uma,
So,
on her
yeah.
tuning fork test? Mhm.
So, you said that Weber's test is lateralized to left.
Yes,
Huh?
ma'am.
So,
Yes.
more hearing loss or more diseased ear is left. So,
Yes,
what should
ma'am.
be the difference in decibels between the two ears for Weber to lateralize?
Ma'am, 5 to 7 decibel should be the difference.
No, not even at 3, Weber can be lateralized. It's more sensitive
Okay,
than
ma'am.
Rene's, more sensitive. So
Okay.
even 3 to 5 decibel difference, and Weber's test can tell us which is the more diseased ear. Okay.
Okay.
The point is that Weber is very sensitive test, and
Yeah.
5 dB we take as average.
Ah.
And yeah, this is that's true. Why there is no sensory neural component, Dipangshi, in this?
Sensory, sir, because
There is a history of long duration of discharge in the left ear, and a history of instillation of local ototoxic drugs, and the drying effect of the air from outside, leading on to there are several factors for causing sensory neural component. Can it happen or not?
so it can happen, but it did not happen in my case. My inner ear was normal, so
What was the duration of eardrops patient had?
I'm on and off. He was not regular in using eardrops. He was taking it from multiple practitioners, and uh, he took it on and off. He was not that regular with the medication. So, and the discharge is only from 1 year, and hearing loss is also since 6 months.
All right. We take it like this. Do you know the pure tone audiometric findings also of this case?
Yes, sir. Yes, I have.
You can tell us.
So I'll go to the pure tone audiometry. So this is my pure tone audiometry, sir, and in the left ear, sir, there is a loss of 35 decibel, and in the right ear, it is of 23 decibel, which corroborates with my tuning fork findings.
All right. Okay. Should you have done the tympanometric test on the right ear?
Yes, sir, I should have done, but I haven't done in this case.
That's important.
Yes, sir.
That's important. You should have done
What
on
do
the right ear.
what do you expect in the tympanometry right here in this case?
Ma'am, in the right ear, it should have been a B-type tympanogram.
B or
Yes.
will it be B or could be C also?
It could be more, it could be C rather than B because it's
Yeah,
totally retracted.
yeah.
Okay.
So there's a lot of middle ear pressure, negative middle ear pressure,
It's
and it could
quite
be
retracted.
okay. Then go back. We were seeing your tuning fork test.
Yes, ma'am.
After that,
I performed the clinical tests. On the right side, the facial or motor function was intact. Spontaneous nystagmus was absent. Fistula test was negative. Cerebellar signs were absent. And on the left side, the facial or motor function was intact. Spontaneous nystagmus was absent. Fistula test was negative, and cerebellar signs were absent.
Dipankshi,
So,
out of all the facial nerve functions, which functions you tested clinically?
sir, I asked the patient to blow his mouth, and sir, I checked if the eye
No,
closure.
you did that. All right.
Yes.
But what function was that? What functions of the facial nerve you have tested? My question is this. What are the different functions of facial nerve?
or which part of the function facial nerve?
You have tested.
Yeah.
I didn't get the
What
questions.
happened? What are the what what are the functions of facial nerve? What are the
So,
functions of any nerve? Any nerve in the
Components of
body?
nerve,
nerve, motor, sensory component, motor component,
Uh, so
and
so this blowing of air you said was
motor activity muscles because of
you've
I'm
written
checking
that, you just explain it.
motor functions. I check
motor
function.
motor function. Motor function of what? Which muscle?
Of which muscles? You elaborate on that, na?
The corrugator muscle, procerus muscle.
No. Blowing of air.
You explain each function with the muscle being
Buccinator,
innervated by the facial nerve.
occipitalis, buccinator muscle. Not that
How
sure.
do you test that?
Buccinator by blowing only.
You said occipital valve.
Buccinator muscle.
Okay, this was buccinator.
Yes, ma'am.
What else did you test for?
Ma'am, procerus and corrugator muscles by seeing for checking with the food.
By
Asking the patient to raise his eyebrows for checking a wrinkling of the forehead.
Okay, Dipankshi.
Yes, sir.
Dipankshi, what motor functions you did not test? Did you follow my question?
Yes, sir.
What motor functions you did not test, or we generally don't test clinically?
I don't know, sir.
You know, you are not trying to recollect. There are muscles supplied by facial nerve which are generally not tested.
Stapedius muscles, sir.
Muscle attachment with the styloid process.
can you tell us the muscles attached to the styloid process? Styloid apparatus. And out of those muscles, which is supplied by facial nerve. That is what Sir wants to know.
Stapedius muscle.
Huh?
I don't
Styloid
know.
process.
Styloid process.
कौन सी मसल्स अटैच होती है स्टाइलोइड प्रोसेस को?
Digastric muscle. Sternocleidomastoid, digastric muscle.
All right. All right. This is okay. This is an exercise for you. How do you test the platysma muscle function?
So by asking the patient to extend his neck.
Can you test clinically or not?
Yes, sir. By asking the patient to extend his neck.
Okay. Extend the neck. No, extension will not contract platysma. You ask the patient to perform certain act. But generally, we don't test this muscle. We are happy with testing the muscles that you have counted. What are the other functions of facial nerve other than motor?
So sensory functions also. So for it is responsible for
Tell us the
lacrimation.
sensory functions.
So responsible for salivation, lacrimation.
Salivation, lacrimation.
Stapedius, nerve to stapedius, and nerve to corda tympani. And there are sensory and motor components, and
Yeah, your voice is not clear. Hello, Dipangshi.
yes, sir.
A bit better, a bit louder.
Ma'am, salivation, lacrimation by the greater superficial petrosal nerve.
You're confusing. It is not salivation. What do you mean is corda? That is what you
Lacrimation.
mean.
Yes, ma'am.
That
Corda
corda is
tympani
not for
and nerve.
salivation. Function is
Yes,
different.
yeah. Taste sensation, ma'am,
So
basically.
it is taste sensation,
Taste sensation.
not
I used the wrong
salivation.
word. Yes,
Yeah,
ma'am.
taste sensation.
Corda tympani, greater superficial petrosal nerve.
Does facial nerve, Dipangshi, does facial nerve has some function at the external auditory meatus and the posterior canal wall?
Yes, so
What
so
is that?
hypoesthesia of the posterior meatal wall. So
What is that known as?
Hitzelberger sign.
What is the condition?
Can you name some clinical condition where it is manifested? You said
Posterior superior meatal wall.
When do
What
you
is
find
it?
numbness in the posterior superior region of the
What?
teeth?
Yeah. Explain it. No, what is the Hitzelberger sign and where it
Hitzelberger
is?
sign. Hypoesthesia of the posterior superior meatal wall is Hitzelberger sign. It is seen
The
with
conditions,
Found
what are
in?
the disease, what are the patients you see when you find this numbness? You've already seen a couple of patients.
I'm not able to recall.
Do you remember the Ramsay Hunt Baba?
Yes, ma'am, Ramsay Hunt syndrome with the patient.
it's all right. It's all right. Ramsay syndrome, herpes zoticus,
Osteoarthritis.
herpes zoster.
Yes.
Okay.
Necrostic neuroma.
All right. So we can move. So you did not find any vestibular function, any dysfunction in the vestibular system on
No,
your
sir.
clinical examination. All right. All right. So you can go ahead now.
Okay, sir. So coming on to the nose examination, there was no external nasal deformity present. On the anterior rhinoscopy, columella was normal, nasal vestibule was normal on both the sides. Nasal septum, there was a spur present on the right side at the level of inferior turbinate, and bilateral inferior turbinates were normal. Nasal mucosa was normal. There was no mass polyp seen, and posterior rhinoscopy examination was normal.
Dibanshi, you have put, just go back to the slide, you have put nasal vestibule examination in the anti-rhinoscopy. It's not anti-rhinoscopy. Before putting the speculum,
Did
you
you
examine.
perform posterior rhinoscopy, Dipangshi?
Yes, sir.
So I have a question. Is posterior rhinoscopy, nowadays
Hello,
most of the
Dipangshi.
centers, they don't do posterior rhinoscopy. So should it be coming in the examination of the long case or not? Because there are different views from the different examiners.
So what do you say, sir?
So should we do diagnostic nasal endoscopy or posterior rhinoscopy? So it is a doubt.
Sir is not audible.
Am I audible, sir?
Now, yes, you are audible now.
Sir, I have a question, sir. While even while helping with students also, I have a query, sir. Nowadays, what we do is nasal endoscopy, diagnostic nasal endoscopy, and we teach all our students posterior endoscopy since we've been doing in our residency also to get an exposure of that. But routinely, many centers, mostly the new centers, they don't do posterior endoscopy. So,
No,
should we be mentioning in this or not?
it's not routinely
We
done.
should side, we manage- we guide
Sir, your voice is
but
breaking.
not.
The
Your voice
internet
is not
connection.
clear. There's
Hello,
some,
about posterior anoscopy.
uh,
My take is that we should say, I tried posterior anoscopy, but patient did not cooperate.
Yes,
that's
sir.
true.
I will
Yes,
write.
This is
Okay,
the
and
safest answer.
yeah,
yeah.
And
that's right.
personally, I don't want any resident to try even posterior anoscopy.
Mhm. And the other thing I was mentioning that nasal vestibule is examined before doing anterior rhinoscopy, before putting the speculum.
Okay, ma'am. I will write.
That is,
That is
which
on
is not to
external
be
examination.
mentioned in the anterior rhinoscopy, right?
Okay, yes, ma'am.
Rightly,
Yeah.
rightly said, sir.
Yeah.
I'll correct it, ma'am. So
It's
your
an
voice.
uncomfortable experience for the always. And vestibule before anterior endoscopy routinely. So there is no scope for posterior endoscopy anymore. Why give discomfort to the patient?
Yes, sir.
Sir, with due respect, I would like to make a comment since this is a valid
Hello?
point. Hello, with due
Yeah.
permission, I
Yes,
would like to
please.
make a comment on this.
Mm, mm.
So in my exam also, it was asked that
Yes.
the idea is to evaluate middle ear cleft as a whole. So we are evaluating the middle ear, we are evaluating the mastoid, but we are missing out the eustachian tube opening. So at some centers now they are providing endoscopes also. Even in MAMC or Lady Harding, in the DNB exams, we have been giving endoscopes or endoscopic unit to the patient, to the resident. So the idea is to evaluate the area around the eustachian tube opening in the nasopharynx. So if we have an endoscope, then there is no need to mention about posterior rhinoscopy.
Exactly, means that area should not be missed during
Yes,
examination,
yes,
whether
yes.
you do posterior
That
rhinoscopy,
completes your middle ear cleft examination as a whole.
which is not because posterior rhinoscopy is not done or not acceptable, so you can give endoscope for diagnostic
Yes,
nasal
yes,
endoscopy. Yes.
yes. Please go ahead.
Without.
Roma, some oldies like us may mind if she doesn't mention posterior anoscopy.
No, I'm not saying say that don't mention. I am saying when you are giving endoscopes or you're mentioning posterior endoscopy, idea is to that area of eustachian tube, nasopharyngeal opening of the eustachian tube is not
Absolutely.
missed.
I think
Yes.
examination of the eustachian tube is more important than
Yes.
than the examination of the nasal cavity in this
Yes.
particular case.
Yes. Because
So
and
the safest reply is I tried posterior endoscopy, could not succeed. However, I performed nasal endoscopy to see the
yeah.
nasopharynx.
Yes.
It's
Yes.
absolutely fine, ma'am. That is why I asked the question, ma'am, because one of our candidates, he was asked to perform posterior rhinoscopy with the laryngeal mirror. Thankfully, he was taught so he could show it. So that is why I had put that question because the earlier examiners they love seeing that IL also indirect laryngoscopy with the mirror also
Yeah,
and posterior rhinoscopy.
now the things are changing otherwise day by day.
You should make a mention of posterior endoscopy, but you preferably do a diagnostic nasal endoscopy
Yes,
to
that
eustachian tube.
Okay, sir.
Yeah. Go ahead, please.
So other ENT examination was normal. So I did perform nasal endoscopy. So can I show the video?
yeah.
Yes, sure.
So this is the left-sided nasal endoscopic picture.
Yeah.
So I could see the middle turbinates,
Mm.
and so I could see adenoids blocking the eustachian tube opening. So
Mm. This is left
Yes.
side.
So beautifully seen. So you can't
Yeah.
see this on posterior anoscopy, this finding,
Mm. And then on
with
the
this
right
much
side also,
clarity.
you did it.
Yes, ma'am, this is right
So
side.
on the right side,
There's
I
a
was able
spur.
to find a spur on the right side nasal cavity, but there was no deviated nasal septum. So
Okay.
shall I give the diagnosis?
Devanshi,
My
this
diagnosis
patient
is
came
chronic
with
otitis
ear
media,
complaints. Did he
left-sided
ever
active
mention in
squamosal
the...
and right-sided inactive mucosal, with
Hello,
left-sided
Devanshi?
moderate conductive hearing loss and
Just
right-sided
wait.
mild
Just
conductive
wait.
hearing loss.
Dipanshi, just
Devanshi,
With
wait.
listen.
spur on the right side and adenoid hypertrophy without any complications.
Just
Devanshi,
listen what.
listen. Listen. Hello, am I audible?
Yeah.
Devanshi, can you listen? Can you hear me?
Yes, yes, we can hear you.
Am I audible?
I think... Am I audible to
Dipanshi,
you, Devanshi?
Dipanshi, can you hear Dr. Sukhdeep?
I think
No.
she's having some issue with her.
Hello? Dipanshi?
Am I audible?
Yes, yes. Now you are
Now,
audible as well as
Am I
visible.
audible to you?
I think she can't hear.
Okay, ma'am, she has some problem with the audio.
Dipanshi? Where's she gone?
डॉक्टर सुखदीप और दीपांशी कहाँ बैठे हैं? कितना कितना दूर है एक दूसरे से?
सर मैं अपने घर पे हूँ, वो अपने घर पे है.
अच्छा. But
Who's
both are
there?
in Panchkula.
Panchkula में भी नहीं.
Sir,
Dr.
I am
Sukhdeep.
in Chandigarh. She is in Panchkula.
Chandigarh.
अच्छा, okay, okay. ठीक है.
Dr. Dipanshi to meeting group not audible. She is not able to.
She's not able to hear anyone, I guess.
So,
I'll just make her a call, ma'am.
उनके नेटवर्क का इशू होगा.
नेटवर्क का इशू है अभी क्योंकि अभी स्क्रीन has come back.
No, she is there, I think now. Yeah.
Dipanshi, are you there?
ma'am, I think she has muted इनका
No.
लैपटॉप पे
Is she?
इसमें म्यूट का बटन
तो
है.
Yeah, now we can hear. Now we can see her. Yeah.
Devanshi, are we all audible to you?
Ma'am, I'll make a call to her. Just a minute. I'll
Yeah,
explain
shall
her.
I join? She wants to rejoin.
Fine.
Yes, yes, yes.
Because she's having some issue.
Yes, yes, you can.
She will rejoin.
You can chat meanwhile.
वो दे दे.
सर कोई स्कोर देख लो कितना हुआ.
मैं वही बोल रही थी मैं भी.
इतने हम स्कोर कोई
स्कोर
स्कोर
अभी
देख लीजिए.
बैच की चैट हो जाएगी.
14-15 रन कुछ हुए.
Plan adenoidectomy also, sir.
What about
Anything to
allergy?
the ear?
And allergy,
Anything to
ma'am,
the ear?
allergy component also, treating the allergy component in the form of oral antihistaminics and sprays. Patient has been using them, but intermittently. So I will give him a full course of
Because there's
antihistaminics.
definite role of allergy as patient is having bilateral pathology.
Yes, ma'am.
So
Anything else you can do to improve the ventilation of right ear also? Can you do something?
Ma'am, grommet insertion can be done if the retractions don't resolve by this. We can put a grommet also.
Yeah, you can keep the patient on follow-up and then you can put a grommet.
Yes, yes, ma'am.
Sir, sorry for intervening. I think Dr. Ravi sir has joined. He was stuck somewhere. Ravi sir, are you there? Hello.
Someone, I am
Hello,
here.
Ravi.
Yes,
Good
yes.
evening, sir.
Good
Welcome,
evening,
Ravi.
sir.
Good evening.
Yes.
Sorry
So
for joining it late.
no issue. Sir, Dipanshi can brief you about the diagnosis and we can take some questions from your end. We are about to finish in 5-10 minutes. So we can take few questions from your side.
Yes, I think we can just continue with the discussion,
Right,
and I will pitch in when required.
right, sir.
Let's
Okay.
let's
Okay,
just
sir.
continue the discussion. I
Okay,
don't want to break the continuity.
right, right.
So we were on to the treatment part.
Yes.
Yes. Yes.
Yes. Tell me.
So, so
Yes, sir.
Dipanshi, you are the
Evening, sir.
operating surgeon. You are the
So,
operating surgeon.
yes, sir.
Hello.
Yes, sir. You're audible, sir.
Now you will decide everything about the anesthesia and the procedure and the approach and the instruments, trolley, everything. What instructions you are going to give to your residents and nurses and other staff in the operation theater.
Okay, sir.
Hmm.
So I would like to do a canal wall down mastectomy in my case. So I am planning for
And
a modified
under
under general anesthesia.
under.
So
Okay. Can you perform this procedure under local anesthesia also?
yes, so I can perform that in local anesthesia also. So,
Have you seen somebody doing it?
so you're not audible, sir. What is your question?
Have you seen somebody
Have you
doing
seen?
this surgery
Yes, sir.
under
In
Yes.
our
local?
institute, yes, sir. In our institution, we have done mastectomies under LA also, sir. Local anesthesia.
So that is majburi when
Yes.
anesthetist जब साथ नहीं देता है, not a choice, sir.
पीएससी
Actually,
में कुछ ना कुछ लिख
Ravi is
देते हैं।
there, and he will. That's why I put this query, because we have been doing in MAMC very routinely under
अंडर
local
लोकल।
anesthesia because of the anesthesia
Yeah.
problem. But ideally, it is not supposed to be done under local anesthesia.
Yes, sir.
Yes, sir.
Yes, sir. It
Ideally, you
is
should always prefer
Under general
GA.
anesthesia, sir.
Yes. So, all right. Anesthesia. What
Sir, your voice is breaking.
before you start? Any special equipment you would like to ensure that it is there with you on the trolley before starting the case?
So for mastoid, sir, I would like to have a drill, sir, and specific burrs for the surgery and micromotor and drill, sir, and all the instruments required for the case, sir. All the micro instruments, sir.
Don't forget the microscope.
Mi- yes, microscope and the burrs, micromotor drill, and all the micro instruments.
What about the facial nerve?
So facial
फेशियल नर्व मॉनिटर।
monitor, facial nerve monitor.
सर मिल जाए तो अच्छा है,
Dr.
वैसे मिलता नहीं
Sukhdeep
है।
will answer this.
जी सर।
हेलो। हाँ,
जी
मेरे
सर, सर
आवाज
योर
नहीं आई
वॉइस इज
आपकी मेरे
क्रैकिंग सर।
को।
हाँ, आवाज सर की ब्रेक कर रही है।
अब आ रही है सर।
ओके।
जी सर।
Monitor, what is your take?
इसको पूछ रहे हैं।
Hello.
हेलो
Hello.
सर, सर। जी सर।
What is your take about facial nerve monitor?
Sir, facial nerve monitor is a beautiful thing if available. But sir, during my residency, I have not seen anybody using facial nerve monitor and doing beautiful mastectomies. In the other surgeries, laryngeal or thyroid surgeries, is definitely it's a wonderful tool. But in mastectomy, it is not very necessary. If it is there, it's an additional thing. But even
So for
facial nerve monitor is
the
not there, we can do without it.
so I think my question was to sensitize our resident that she should talk about this also. If you have it, very well. If you don't have, then also you can proceed.
Yes, sir.
यस।
Sir,
Yes.
I got it complimentary. Medtronics people, they had come. I had requested them, and I showed my residents facial nerve monitor during mastectomy, so as to expose them.
Yeah.
Otherwise, it is not necessary.
So,
My second query
So,
is, she will attempt it endoscopically or microscopically or both.
so microscopically. So we have done it microscopically in our institution, but we can
Okay.
do it, sir, endoscopically also, sir.
Actually, both, sir.
If you
Yes,
are
sir.
if you are doing microscopically,
Yes, sir.
will you like to keep the endoscope also with you?
Yes, sir, to see the hidden areas, to inspect if the cholesteatoma I have removed from all the hidden areas, sir.
For
For that
example,
endoscopy.
Yeah.
for example,
So,
Uh,
sinus tympani, facial
yes,
recess.
yes.
yes, Dr. Ravi wanted to say something.
Yes, so I have just one comment regarding facial monitor.
Hmm.
So it is not a substitute to your anatomical knowledge of facial now, right?
Absolutely, sir.
You cannot, you cannot substitute facial monitor with the anatomy of anatomical knowledge, because if you don't know the anatomy, you should not be doing the surgery, right? So,
Absolutely.
right, anatomy of the facial nerve is very, very important, and a student or resident who is performing a mastectomy must undertake some temporal bone dissection before venturing into a live patient. So that is my take. Can you tell me what are the boundaries of sinus tympani, Dr.
Uh,
Dipanshi?
yes, sir,
Boundaries?
So it is bounded superiorly by ponticulus, sir, inferiorly by subiculum, sir,
Mhm.
and sir, laterally by the anteriorly by the posterior semicircular canal, sir.
Anteriorly.
So
You have
laterally,
put
sir.
superiorly, you have
Later, inferiorly, sir, laterally and medially, sir, not anteriorly,
lately is
posteriorly.
bounded by
So medially it is by posterior semicircular canal and laterally is by the facial nerve, so
Yeah.
Vertical
How do you
segment.
decide the
vertical
depth of the
segment of the
sinus
facial
tympani?
nerve. Yes, sir.
Mhm. Okay, so
Ma'am,
the question is, how do you decide the depth of sinus tympani?
depth of sinus tympani. So there are three anatomical variations for sinus tympani type A, B, and C.
Okay,
Hmm.
very
Yes.
So it is medial to the facial nerve.
okay. So it is till the anterior part of the facial nerve.
Yes, sir. Then, sir, it is medial to the facial nerve. Then it is, sir, posterior or deep to the facial nerve type C,
Very
sir.
good.
Very good.
Yes, sir.
So suppose
Okay.
there is a deep sinus tympani and there is a cholestoma going into the sinus tympani. How you are going to visualize it and remove it?
Sir, endoscopically only we can visualize
You are able to visualize it with a maybe with a 30-degree. How you are going to remove it?
angle.
See, instruments will not be, you will not be able to
Angled
insert
endoscope,
instruments there.
we'll need an angled endoscope to pele firstly visualize it
You have
and
visualized
then.
it. You are able to
Okay, sir.
visualize it, but
Yes,
how
sir.
to remove it? So what will you do? What extra thing you will do to actually
So,
make this sinus tympani more shallow? Right now it is very deep, but what will you do to make it more shallow so that you can actually reach
Access
the
it.
posterior tympanotomy
no posterior
option.
tympanotomy?
That is
Does
an
it
approach.
Facial recess, just to see the
that is the
patient.
approach to through the facial layer. You will not be able to
Yes,
see the sinus tympani. So what will you do?
sir, I don't know.
I remember Dr. Pasi always telling to thin the posterior
Anterior
Yes.
canal
end.
wall
See, it
from
is
the
deep because
anterior
of
side.
facial, so make it less deep.
Okay,
No, you have to actually drill the anterior part of the posterior
Facial
canal wall,
canal.
thinning of the
sir.
anterior part of the posterior canal, so that the sinus tympani, which is more deep, will become more shallow, and you
Okay,
can
sir.
do till the facial sheath, right? So that is how
Okay,
you
sir.
can actually make it more shallow, and then you can use
Remove.
angled instruments,
Endoscope. Yes, angled
not in
endoscope.
angled
Okay, sir.
instruments. And angled endoscope is for visualization. How to
Okay,
read?
sir.
So you can use angled suction elevators
Okay, sir.
or suction curettes, which can actually reach that area and then try to remove the disease.
Okay, sir.
So two things: one is the thinning of the posterior canal wall from the anterior part, and second is using an angled instrument to reach that area.
Okay, sir.
Okay.
I think.
Uh, Dr. Ravi, I also use circular knife
Hmm.
to take out, to scoop out the
Yes. Yes.
cholesteatoma from the sinus tympani.
Right. Yes. So circular knife or a angled instrument. Circular knife is also angled, right? It is angled at,
Yes,
Yeah.
that is angled.
yeah. So that is a good instrument to actually, or you can sometimes use a angled ball probe, right?
Hmm.
Yes.
Yes.
One of the instrument which can be used. So it is more or less less traumatic than other instruments. Okay. So what are the four sinuses in relation to the pyramid?
Yes, Dipanshi, are you there?
Yes, ma'am,
सुखदेव
I'm there.
सुखदेव उसको डांटो मत.
नहीं सर, मुझे लगा उसका फिर से हैंग हो गया.
नहीं नहीं ma'am.
सर इस पे तो अगर नहीं बताएगी तो खूब डांट पड़ेगी.
कल करना, कल, आज नहीं.
Posterior sinus. I'm not sure.
Posterior.
Okay.
Sinus tympani.
Yes.
Okay. उसका नाम क्या है?
And
सर ने बोला पिरामिड के साथ, तो उसके नाम से ही बताओ.
pyramidal eminence.
हाँ वो
Eminence.
एमिनेंस है, उसका साइनस का क्या नाम
एमिनेंस.
है?
एमिनेंस तो एमिनेंस से साइनस कैसे हो
उसके
सकती है?
नीचे क्या होगा?
Sinus.
देखो, दो तो तुम्हें पता ही है, sinus
हाँ
tympani
जी
and
sir.
facial recess.
Yes sir. Okay.
They are two very very important sinuses which you already know. So
Yes sir.
first
तीसरा तुमने अभी सर अभी पोस्टीरियर साइनस भी बोला इसने.
tympanic sinus
Yes
आपने
sir.
बता ही दिया.
Tympanic. Yes sir. Tympanic.
अब सबसे सिंपल रह गई.
अब रहेगा, उसको हम कहते हैं सब टिम्पैनिक
सब
साइनस.
या
Subtympanic sinus.
और सब पिरामिडल.
फोर साइनस.
mean-
ये pyramidal process जो है ना, it's like a pivot, and around that we have four sinuses, right? Two lateral to the facial nerve and two medial to facial nerve, right?
Okay sir.
So these are the sinus tympani, the facial recess, the posterior tympanic sinus, and the sinus subtympanicus. Right? So this is basically endoscopic anatomy or retrotympanum, and sometimes you can get a long question because this endoscopic anatomy is recently discovered with the use of endoscope. So many
Yeah.
times in your exams, you can be actually asked about the anatomy, endoscopic anatomy of retrotympanum, right? So you have to write all these four sinuses along with the subiculum, the inferior retrotympanum, and then the hypotympanum. So what are the structures which are dividing, like funiculus, fustes, and the
Protiniculus,
Jugular bulb. Jugular.
ponticulus.
ponticulus. Right? All these
Yes.
structures should be knowing, and you have to describe the anatomy of the retrotympanum, endoscopic anatomy, which is we seen only with endoscope, not with microscope. Because when you are using a microscope, you are seeing at an angle, and the posterior canal wall actually hides the retrotympanum, right?
Yes.
But when you are using an endoscope, you are using through the uh, permeatal route or through the canal. And because of the wide angle view of the endoscope, you are able to see all this anatomy, which is hidden by posterior canal wall in case of microscopic.
It's much better than microscope.
Much,
We'll
much,
see.
much better, man.
Yeah.
So I think Dr.
Is,
Pasi
is the
sir.
time up? Is the time up?
Time is already over, I think, sir.
Okay, sir.
मैं उससे लास्ट क्वेश्चन पूछूंगा
हाँ
दीपांशी
जी,
से.
हाँ जी सर.
Yes.
दीपांशी बेटे, अब ये बता दो कि तुम लेब्रिंथाइन फिस्टुला का केस है, क्या प्रिकॉशन करोगी तुम स्टार्ट खोलने से लेकर के फिस्टुला को मैनेज करने तक? What precautions you are going to keep in mind after you have opened up the mastoid antrum?
During the surgery, no?
Yeah, of course.
During the surgery. Yes.
Sir is asking, there is a fistula, माने वो खुला पड़ा है.
Mhm.
What precautions you should be taking?
Not drilling.
मतलब वहाँ क्या नहीं होना चाहिए?
इंजरी नहीं होनी चाहिए मैम वहाँ पे.
तो कैसे
वो
होती
ऑलरेडी
है?
हुई हुई है.
आपने और इंजरी, फर्दर
एक्सपोज
इंजरी
नहीं
से
करना.
एक्सपोज भी है ना? फिस्टुला
एक्सपोज्ड है तो वहाँ क्या नहीं होना चाहिए? क्या वहाँ नहीं जाना चाहिए?
मैम बर नहीं टच करना चाहिए हम जो ड्रिल कर रहे हैं तो.
पर तो
और
हम वहाँ जाएंगे ही नहीं.
ड्रिल तो करेंगे ही नहीं ना, वहाँ पे सक्शन नहीं टच करना
और
चाहिए.
वहाँ
Okay.
सक्शन नहीं जाना
Suction नहीं
चाहिए.
जाना
जो
चाहिए.
ड्रिल कर रहे हैं उसका
Just
डस्ट नहीं जाना
हीट
चाहिए.
नहीं जाना चाहिए तो
heat
इरिगेशन एंड सक्शनिंग अवॉइडेड होना चाहिए. मतलब कांस्टेंट इरिगेशन के साथ ड्रिल करना चाहिए.
और सक्शनिंग नहीं होनी चाहिए, डायरेक्ट सक्शनिंग ओवर दैट एरिया.
So you're
Sir, we
not
are not
audible.
able to appreciate.
operatively.
Sir,
Sir, please
so
repeat.
what is your question?
Not audible, sir.
What can happen if you accidentally touch your suction tip right on the top of the canal fistula.
Yes, what can happen?
So patient can have
Can I have
vertigo,
what?
vertigo and nystagmus. Can
Yes.
patient can have that post-operatively.
Even intra also.
Yes, ma'am.
Anything
So,
else, sir?
so I just tell you something about the management of lateral semicircular canal fistula, which is seen because of cholestoma. Cholestoma can actually destroy the labyrinthine bone and can result in fistula. So, when you are dealing with a fistula, you must always anticipate a fistula and you must get a CT scan done, right? Or any patient having history of vertigo, get a CT scan done, and CT scan can actually diagnose lateral semicircular fistula, right? You can know pre-operatively. So if you know that, you have to tackle the fistula in the end. You do all the mastoid part of the surgery. You remove all the disease from the middle ear cleft from everywhere, lower the canal wall, do all the things, and in the end you tackle the fistula, right? So fistula, how you tackle? You might have a cholestoma lining the fistula, right? So there are two things which can be done. If it is a very very small fistula, you can just gently peel off the matrix of the cholestoma
Cholesterol.
from the fistula side and just cover it with the piece of fascia or cartilage, right? That will is sufficient. Do not use suction on the fistula. Very very important. Second, if it is a large fistula and if you think that this I will not be able to remove the cholestoma matrix from this area, and this is going to cause trauma to the the membranous
Cholesterol.
labyrinth is inside or endosteal layer of the inner ear, then you can actually leave that cholestoma, small area of matrix over the fistula and graft rest of the tympanic membrane, graft
Sir.
rest of the mastoid cavity and the tympanic membrane. You can leave that cholestoma, because what is cholestoma? Cholestoma is a squamous epithelium,
Mr. Putin.
right?
Yeah.
So even if you leave that small matrix over the fistula, it is going to epithelize the cavity, right?
Okay, sir.
But the problem with this is that patient might have dizziness episode after the surgery also, because it is open. So any cold or hot air going into the mastoid cavity can result in stimulation of the
Vertex.
labyrinth, thermal stimulation of labyrinth,
Yes, sir.
leading to
Caloric effect.
leading to caloric effect, and patient will have many times you can actually cover the cholestoma matrix also, and what will happen, you have to revisit it because it will form a small cholestoma pearl,
Okay,
right?
sir.
So that is the thing. Large fistula must be covered with a cartilage, right? So you remove the matrix gently and just immediately covered with a cartilage and then put the graft. So that is the management of a labyrinthine fistula.
Thank you, sir.
Thank you so much, sir.
I think we have had enough
Enough.
discussion.
Yeah.
Yes, sir.
Yeah.
Yes, sir.
Mm.
Back
So
Okay,
to
can
sir.
Dr.
can
Raman
we
and
close?
Right,
Dr.
sir.
Bhushan.
Can we? Hi, sir.
Right.
Can we close the session now?
Yes, yes,
Yes,
sir.
yes.
Yes,
We
sir.
Yeah.
Before we
closed, sir.
close the session, sir, I'm feeling very blessed today. Sir was my examiner, and now sir is my student's examiner.
Yeah.
So,
Great.
sir, I just
I'm
want to make a
really
comment
blessed.
before we end. So, sir, actually, this year we were planning some other activity for Haryana AOI, not these regular routine sessions. So that we'll be proposing in executive body meeting that is to be held in Karnal this month. But I got a request from the residents from civil. Sukhi ma'am first called me that we want
Thank
our
you so much.
resident to participate and she wants to present her case. So it even we feel very happy that we don't have to run after the HODs or different medical colleges that please ask your resident to participate. So we are getting the request from the resident. It means a lot to us. So that is why
Yeah.
we did effort and we held this online meeting, and we want such kind of participation from
Thank you,
the
sir.
side of residents or their HODs rather
Thank
than
you so much.
we are after the HODs. So thank you very much. And Dipanshi, this is a big, you have shown good courage to present this case. This is not an easy task to present online. And we'll be holding much more activities for all the residents in future. So thank you very much to all the experts for agreeing to be an expert at such a short notice. Now over to Bhushan sir or Uma ma'am, we can conclude the session.
Yeah, on behalf of AOI Haryana, yes, I would like to thank everyone for joining this session today. We couldn't do this session earlier in last 2 months, but I think Raman is taking great efforts in organizing these webinars. So, Raman, I'll be looking forward to have your ideas during the upcoming executive body meeting. So, thanks once again. And I think it's already very late. So, good night and now enjoy the match.
Yeah.
Thank you so much.
Thank you.
Sir.
Thank you.
Thank
Thank
you.
you.
Thank
Thank you,
you.
sir.
Thank you.
Okay, good night. Good
Okay.
night,
Good
everyone.
night,
Good night.
sir.
Good
Good
night.
night.
Bye.
Good night.
Thank you.
Bye.
Thank
Bye,
you.
sir.
Thank you. Thank you. Thank you.